And what the Fed's was saying is we got to change sport. Only so many fish in the lake. We need to more appropriately steward the situation. So we're going to change from fishing to football. So our communities have these resources, but we need to care for our community team, if you will. And there's 11 people on the team-based deal. Everybody has their own unique role. The hospital, the physicians, everybody's got their own deal. But they've got to be coordinated. They have to start at the same time. They stop at the same time. We've got to have coordinated care as we deliver this. We move forward together. The team goes forward down the field or they get penalized together. And we're only going to win the game together. It's a new deal. So if you come in thinking you're here to kind of protect your segment, I'm going to ask you to change your segment. But thinking about your segment is your position on the team, left tackles. Don't be thinking about that. You need to be thinking about how you move your team, which is your community. So Berwick kind of introduced this stuff, and this is a game changer that says we're moving from a volume-based system to a value-based system, okay? But this is the kind of stuff you have to do to win in a value-based system. Do we have any questions about that? Okay, the world just changed. Next slide. Secretary Burwell published this quote in 2015. Basically, I mentioned that I've been hearing this stuff since, all my career, but they really put a timeline on it. We're really doing it. And basically they said, we're not only going from volume to value, but we have expectations on what the journey looks like. So new targets have been set. That's the whole point. New targets have been set for value-based payment. 85% of fee-for-service all your value by 2016, and 30% of those have been are expected to be in a risk-sharing arrangement and technology. How do they want to get there? Their strategy to drive the progress. They're going to have incentives in place to reward high-quality care. They're changing the way we're going to get paid. It's no longer how many widgets you can generate. We're going to get paid on how well your widgets work going forward. Okay? So improving the way care is delivered. We are here to figure out how we block and tackle together. Okay? So how do we integrate and run plays together? I got to tell you, I've been talking to docs about this fishing to football thing for 10 years, and at first it was, no, we'll never do that. Providers, we'll never go there. And now they're starting to get it. They're starting to acknowledge that we're going to have to play football. Of course, when they do that, it's like they all walk up to the line of scrimmage with their fishing rod. Okay? It's like, really, okay, how many of those value things do I have to do? They're really into the RV thing. So, and that's one of the things we have to deal with as we go forward. Okay? So improving the way care is delivered, you guys are the ones who have to be both the confidant, coach, and the illuminator on how we move our clinic system to where it needs to go. And we need to figure out how to do what we are doing today better and better and better. We've got to accelerate this process. We need to figure out how we use this information to not only improve the system, but to get information to our providers better. Next slide. This is kind of a weird slide, like an onset target. I have seen this before, but if you look at the gray circle here, obviously 2016, 20, these are the federal targets. 2016, all the gray are for service payments. They want in this year, by the end of this year, they want 85% of our fee-for-service payments to have some kind of a quality measure tied to it. Why? Anybody around in the 1990s when we did Managed Care 1.0? Okay. What happened there was in Managed Care 1.0, we're going to improve value. Now, value, here's your math. Value equals quality divided by cost. What I get versus what I paid for, that's value. In the 90s, how did we measure quality? Where did he go to medical school? Are they a good hospital? Might be, they have a fountain. Do they throw things? for surgeons. We didn't have really good objective metrics of quality. So because we didn't have good metrics, value equals 1 over cost. Now, if everybody remembers algebra, basically we can improve the value of cost. And we all know how that works. Went for about 3 or 4 years. Consumers started to say, wait a minute, what do you mean I can't go to the doctor I want to go to? The other thing that happened was the clinicians began to say, now wait a minute. That's not good medicine. And I get sued if it's not good medicine. So what happened is the physicians and the clinicians and all the hospital, everybody said, wait a minute. And we started to kind of say, you can't just the insurance company telling us we need to do this stuff. We need to have more information. And it was the genesis of this body of knowledge we now take for granted called evidence-based medicine. Okay, all this stuff now. And we use that now for clinical guidelines, metric assignments. So the point is today, in managed care 2.0, value equals quality divided by cost. Oh my goodness. We have over 800 metrics that have been endorsed by potential quality. We have stuff that we're gathering now, and CMS puts out on Hospital Compare and physicians. We've got all kinds of data out there. The question is, are we using it now to actually improve value? Most of the time, the answer would be no. What we do is we take our measures, we say, here they are, let's put them on a scorecard, and I'm good. They're not. You should come to me. Probably not real good performance improvement. That's just targeting people where they should purchase. But what we're challenged to do now is start to use this information. This is where it gets hard, guys. This is why it comes to you. We need to use this information now to come and look at our internal processes and embed performance improvement in the way we deliver care on a regular basis. Now, I know this is a convoluted story, but you know why this is so important? Because the feds don't think that we can do this unless the provider community, the provider community is being asked to prove us out of our federal. We have to reinvent the way care is done. That's why you're here. We're here to create a big thinking learning community. We can kind of take the best practices from everyone, work them in, keep tuning the fiddle as we go forward with this care. What are they going to do to incentivize this? Go back to this. So 100% is the gray, 85% of it now. Goal is that by the end of this year, 85% of it we have quality metrics, so we can at least track the value on what we're doing. With me on that. The other thing they want us to do is, that's in the fee-for-service system. They want us out of the fee-for-service system. They want us taking risk. They want us saying, we'll take care of this population for X number of dollars. They want to have a predictable budget. And by the way, if we take care of it for this number of dollars, if we exceed those number of dollars, they go, too bad, because at least they have a predictable budget. If we do better than those number of dollars, we profit. We can put that into R&D or whatever we want to do. But the whole point is they want a predictable system, and the advanced payment methodologies give the federal government a predictable budget going forward. So the goal is they wanted to have us, by the end of this year, 30% of our providers or of our dollars in a risk arrangement. The interesting thing is by 18, they want to move from 85 to 90%. Having value, so we want to have more value. They want to have 50% of the dollars in methodology. Many of you may have heard last month, President Obama announced 30% of payments in the United States are now in risk arrangement. 30% are now tied to a risk arrangement. That does not mean that 30% of the physicians and the clinicians are paid on a risk methodology. Two pieces there. Did the organization take risk? Yes. Have they figured out, once they've taken the risk, how to have their system operate differently and pay their providers and have them execute on a value-based methodology? No. Big disconnect. Why is that so important? Because we are being encouraged as institutions to take risk. okay? And if we aren't ready to take, and that's this other thing is, are we ready to take risk? Okay? So the whole point is, if we take risk and we're not ready to take the risk, who wins? Not us. Payers win. Medicare wins. And I'm not trying to demonize anybody because this is about a national effort of trying to stabilize our budget. But the fact is, we are highly incented to figure out how to block and tackle now. We're going to be increasingly incented to get into risk. You guys with me on this stuff? I know this is kind of early in the morning, heavy economic crap. Yes.
Do you know what the are?
I'm sure somebody has that, but I don't know. The more interesting question is, and do you know of that 30% that are already at risk, have their physicians in some kind of a risk arrangement, their providers at a risk arrangement, so they're actually responsibly managing risk? And the scarier thought is they don't know that either. They just know there's a big disconnect. They know that their good news is they're getting the risk, but the question is, how do we sustain the risk that we take? You realize what the problem is. We can improve ourselves. This may not be a sustainable situation if we can't navigate the difference between taking risk and being able to execute the risk-based environment. We've got to do value-based care. TCPI is about bringing you resources to help you bridge the gap. It's about helping you guys figure out, okay, either see, the beauty is if you're in TCPI, you're not at risk, but this is about helping you do this stuff so that you will be ready to take risk. Which you do, preferably, which would you do? Take risk and then figure it out, or figure it out and then take risk? Preferably, you figure it out and then take risk. That's what TCPI is. Figure it out, and then we're ready to go from myths to one of the higher levels. Next slide. Everybody familiar with the sustainable growth rate? Okay, this is, everybody's heard about MACRA. You can't talk about MACRA until you go back to 1997. This is a story, so I apologize if I get too weird here, but this is about Part B reimbursement, okay? So our Part B reimbursement, going back here over time, CMS is trying to figure out how do we get the provider community to begin to recognize, bend their cost curve. And they tried everything they knew how to do, and the Part A stuff they could move, Part B wasn't moving. They needed to get I'm just going to use the term physicians generically here, but anybody who's paid in Part B. 1997, they said, okay, what we're going to do, we're going to take all of the Part B pile of money, and what we're going to do is we're going to just contract that by 2% every few years. And what that will do is the provider community will just have to learn performance improvement. They'll have to learn how to do this because they're going to have to get more efficient. So what they did is say, okay, we're going to build a budget based on that revenue contraction over time. It'll get us to where we need to be, and the providers will have a nice glide path to learn how to do performance improvement. Sounded good when they proposed it. Started in 1997, like 2001 was going to be the first speed bump that they run into for revenue contraction. Got passed in the Clinton administration. So you can imagine what happened. Everybody, okay, yeah, we'll do that. Excuse me, I have to go see patients. So we have that approved. What happened? We come around to 2001, time for revenue contraction. Time for this thing to kick in. We're going to decrease the rates. And what happened was the provider community came out of their seat. Whoa, you can't do that. We'll go out of business. If we go to, we won't be able to take Medicare anymore. And everybody starts worried that we're going to lose the number of people that are taking Medicare. So Congress blinked. Congress said, okay, we won't take away your money, but we're serious. You need to learn this performance improvement stuff. So what we're going to do is we won't reduce your payment now, but this 2% will be added on to the next 2% in 2 years. So we'll kick the can down the road. So in 2 years, it'll be a 4% reduction. You all understand that? Yeah, we understand that. Okay, so thanks. Now, stupid, we have to see patients. We go back to see patients, and you can imagine what happened. Nothing. So we go through time, we get to the next speed bump. Guess what happened? Oh, you can't do that. We'll go out of business. And same thing happened. Congress blinked again. And they said, okay, we're really serious this time. So we won't reduce you now, but next time it's going to, matter of fact, we'll give you a 0.5% increase. But the next time it's going to be a 6% reduction. So we had these cycles, these speed bumps that we ran into 17 times. Now, after about the fifth, people are kind of going, this ain't going to work, guys. We got to find a different model. So number one, they started working on a different model in the early 2000s. The second thing was, it's interesting, the provider community kept saying, you can't arbitrarily reduce the amount of money you pay to all of us. You should base this on quality, because we're quality. We're quality doctors. And you should make it that the quality doctors get paid more and the non-quality doctors get paid not as much. So CMS goes, okay. So they started working on a system. Now, first of all, usually, like in a room like this, when I have this many people, I have done this with a group of 500 even, but I usually, if you're all physicians, and I say, how many of you practice in the lower 50th percentile? Raise your hand. And so, frankly, how many of you practice in the lower 50th percentile for your clinics? Do you see any hands? Okay. Now, I got to tell you, 50% of you are in here. But the whole point is, and with physicians, it's kind of interesting. I'll tell this, but out of all I've been doing that for 10 years. And out of all the time I've done it, I've only had one physician raise his hand. And it was actually a physician from South Dakota. Yeah. And then he said, just kidding. but the whole point is, there's a powerful, powerful incentive in the provider community that we want to do good. It's not just physicians. Every one of you in this room could probably make more money someplace else, but you are here because there's something about helping people. So the point I'm making is that with the SGR gone, and everybody, the physicians said they wanted a different payment system. So the last speed bump we hit was in 2014. The reduction would have been somewhere between 27 and 32%. And they kicked the can down the road one more time to March of 2015, where they actually had the macro legislation available. It was passed by Congress in 2015, signed by President Obama in April of 2015. This is an important point. MACRA was the solution to a painful problem. MACRA was passed by the Congress that was a Republican House, Republican Senate, Democratic President. It's a strongly bipartisan piece of legislation. The Senate vote was 92. The House vote was a similar percentage. This is one of the most bipartisan supported piece of legislation we've seen in the last 20 years. Okay? This is important, folks. This is not going away. The Congress of the United States has said the way we're going to bend the cost curve is by embracing value-based care. The reason I'm telling you this is not the Affordable Care Act. The Affordable Care Act, which is basically an insurance reform bill, that everybody kind of just lumps the two together and says, well, you know, we'll get a different president and they'll repeal that Obamacare stuff and we'll go back to the good old days. Not. Frankly, this is completely separate than the Affordable Care Act. The Affordable Care Act, Democratic House, Democratic Senate, Democratic President, purely unilateral thing, and it's created wonderful political theater for the last 7 or 8 years. But the fact is, this ain't it. This is the way they're going to actually bend the cost curve, and this is the way physicians and clinicians are going to be paid going forward. So, what are the components of MACRA? Pretty much, well, number one, it is the law, and it's not going away. Number two, you can see that it's permanently stealing the sustainable growth rate stuff. All that speed bump stuff is okay, and it's gone now. It's not like someday, it's gone now. The fact that it's gone now shows you how committed they are that this thing ain't going away. Okay. What this does is it changes your Medicare payment, and it basically says there is a 4-tiered system for payment. Think of a ladder. The first rung is MIPS, and then the next 3 rungs are advanced payment methodology. Your clinicians will be paid on the ladder. And you're either going to be in an advanced payment methodology or you're going to be in MIPS, but you're not going to get to stand on the floor anymore. You've got to be somewhere there. If you choose not to go to the first rung, that's your option, but we're still going to calculate a score on you. and they're still going to pay you that way. So the whole point is, this is our chance to help our clinicians step onto the first rung. I'm not going to talk about rungs 2 through 4 here. I'm not going to spend a lot of time talking about the methodologies, other than to tell you, hey, that's where the federal government wants. B, which means at risk. B, it is more money. There are performance issues that are written into that they will bring you more money, not less. So it is tiered, and to learn how to block and tackle, take risks. Okay? The problem is most of us can't even get to walk up the ladder. So we got to figure out how do we this first level of merit-based incentive payment system is kind of the first rung. You got to do the first rung. So I'm going to spend quite a bit of time talking about, and by the way, if you master the rung, the whole point is that if you master the stuff in the first rung, you will be at least prepared to play in the APM. So what we're PCPI about equipping you to do well in your base. Are you okay with this? Kind of got it? Fine. We're going to talk about MIPS. So what is MIPS? MIPS starts January 1st, 2019. What does that mean? That means show me the money. That means your payment is impacted January 1st, 2019. Your paycheck changes. Now, your clinic systems could be part of a health system. And as we're part of a health system, our health system now, they guarantee our physician salaries. So this won't affect us, right? Wrong. Because how do you think your health system is going to get reimbursed? Your health system, all of this stuff, this is basically the cash pipeline coming into your health system. So a lot of clinics and a lot of physicians I talk to say, oh, well, yeah, but that's somebody else's problem. Wrong. As a matter of fact, this is probably more than you wanted, but think about it this way. For whoever is at risk, whoever is getting paid for Medicare has got to figure out how they're going to bend the performance of their clinicians to be able to do this, so they're going to lose money. Okay? So, begins on January, oops, go back.
Sorry.
That's okay. So, begins January 1st. That's nice. How are they going to know what to pay me? Basically, they're going to base it on the performance from 2017 and 2018. So, whatever your numbers look like, that's the formula that we use to calculate your payments in 2019. What does it look like? We've got all these little science projects that we've been doing for the last several years. PQRS, the value-based modifier, all these nice little things, meaningful use. Those things are going to be smushed together now into a score. Think about it when you were in college and you took all these classes and then they averaged it into a grade point average at the end. That's your MIPS score. That's going to be your grade point average. You don't get to only do one of the classes. You got to do all of them. It's going to be mushed together into a score. And that score will be ranked on a 0 to 100 level. Ready for this? National. National. This isn't just like, oh, we'll only compare against the other physicians or the upper Midwest. National. So it's going to be a national score, which, by the way, I think is good news for us. But then, and then your score will go, your payment will go up or down, dependent on that. Now, up or down, here's the other important thing. The pot is fixed. They're not printing any more money. The pot will be fixed. So the distribution of the pot will depend on the MIPS score. If you're someone with a 92, you're probably going to make more money. If you're someone with a 7, you're probably going to make less money. And the person who makes more money got some of the person who got less money's money. Okay, so it's just going to be a redistribution mechanism. Okay, so now we're all back in medical school again. We're all got to compete for every stinking grade. But that's what the deal is. It's a budget neutral program. It can go up, it can go down, it can be negative. I would bet that it will be neutral for most people on the front end, but not forever. And then the score will, again, you'll be able to use the MIPS to determine. So next slide. This is kind of the timeline, and this is complicated, so I'm going to kind of walk you through this. But notice we got from 2015 through 2026, 10-year time frame. This is a long journey. I heard somebody say the other day, this is not just a long journey, this is a very long journey, but it's really, but we're really going. Okay, so 10-year journey. And I'm going to go back here. I want you to mark right about here, 2019. There's pre-mix, pre-mix and post-mix. In the pre-mix period, what's going on? We're in this now, 2015, 2016. We were signed in 2015. 2016 is kind of our get our act together year. And then, so notice in that period, we've got these existing programs, PQRS, value-based modifier, EHR, all of that stuff continues through the end of 2018, and then it stops. And it moves, all of those scores go directly into the mix. Okay, so those programs are no longer, there's not a revenue stream tied. The next, the gray slide there, yep, STR has been repealed, it's gone, ding dong, the witch is dead. We can figure out a way forward. There are going to be updates in physician payments. It's interesting, with this, we've waited with the STR, if we could instead of a 7% decrease, lines at 0.5% increase, we're going to get there's 0.5% written in through the end of 2019, and then any increases go to zero. Which any increase every time you win store. Think you're serious yet? Yeah. Okay. Now notice that at the end of 2026, this is kind of like reboot. We'll see where we're going from there. This is a 10-year plan that got. Now what about next? Okay. We're going to start the measurement cycle beginning in 2017. So PQRS, meaningful use. If you're not doing those things, you better be doing those things. And you better, and the other, so that's point number one. Because think about this. You're going to take a test, and a certain percentage of the questions are on PQRS. If you decide not to answer those, what's that going to do to your score? Right? So for meaningful use, so you got number one, if you're not doing them, figure out how you're going to do them. And number two, this program, TCPI, is about trying to figure out how we now embed the skills internally to get better scores. This is your study group. This is how we're going to try to figure out how we do this better. So starting the cycle, and TCPI actually goes through about here. Okay. So starting the next measurement cycle, 2019 it kicks in. What happens with the payment? You can go up or down, but it's limited. You only go up or down maximum 4%. So you can only have a 4% decrease. But in 2020, 5% decrease. 2021, 7%, and then from 2022 on, a 9%. So this is real money, and it's annual. Okay. So do you think we're incented to try to figure out how we block and tackle better and better within our clinics? You see the challenge now? We got to get our physicians and our clinicians engaged in this. We need to start looking about how we actually deliver packages of care, process mapping that out, and then using kind of performance improvement techniques to go, okay, now let's make a few tweaks because we think we can do this to have our numbers improve. And we'll just go through those cycles of improvements as we go forward. Next slide. So if you look at your MIPS score, and this is a better way of looking at this is that this is what it's going to look like, the rough percentages of those different programs in 2022. At full deployment, the estimate is that quality measures, or PQRS, will make up about 30% of it. Meaningful use of your electronic health records, okay, meaningful use is going to be about 25%. And there's two new categories. Resource utilization. What is resource utilization? It's how often do we do dumb stuff. There's going to be an increasing focus to be better stewards of healthcare resources. So imagine, anybody heard of Choosing Wisely campaign? Okay, the Choosing Wisely campaign is basically about stewardship. How often are we doing things that are not good for the patients, even if the patient wants it done? Case in point, somebody comes in and they strained their back. Low back pain is an incredibly common family medicine diagnosis. And this person is, they were just having back spasm and they're in terrible pain. They're very, very frustrated. You got to fix me, doc. I think I'm dying, and I got to have some X-rays, and that'll make me better. And I know that doesn't. You don't need back films. I mean, you need to almost relax or lay down and kind of take it easy a day or two to be better. But no, I got to have this, and then they start to get mad because you won't give them their X-rays. The patients think it's the right thing to do, and it's not. So then you acquiesce and you give them back films and it doesn't tell you anything, and then you give them their muscle relaxer and their anti-inflammatory, and then they go home better 2 days. And they think it was, oh, but at least I don't have, broke it back. Well, frankly, X-rays are not diagnostic. They're not therapeutic, but they do expose our patients to radiation. Okay? So it's basically bad medicine, but it was patient-driven bad medicine. Choosing Wisely is a campaign where a bunch of medical specialties have gotten together and tried to identify specific, at least these clusters of 5 specific things that you should not do. There are things that we and we try to equip the clinicians to go to the patients and say, that films are the worst thing for you right now. Okay, so those are examples of utilization measures that we're going to be expected now to bend the curve with our patients. So there's going to be about 30% going to be tied to how well we're utilizing the healthcare resources. And by the way, that's not just primary care. Primary care, specialty care, across the whole system, they're going to have these.
Whole rule that came out on the 27th, which shows the quality is now 50% and the resources and cost at 10 or 17. So
hold that thought. That's the next slide.
That hurts.
Yep. Well, remember, this is 2022.
Yeah.
So even though it says 2019, it's really 2022. This is the full deployment picture of that. You're exactly right. So there's going to be at full deployment 30% here, and then there are going to be these new measures on basically how do we deliver care, patient access, that kind of thing. So new measures that how the style with which we deliver care is also going to be measured going forward. Now, the point is, these aren't developed yet, and the point that you're making, these aren't developed yet, and these aren't developed yet. So if we're going to kick this thing in 2019, what's it going to look like? Next slide, Dan. So this is the expected percentages of each of these. This is, ready guys, we're teaching to the test. Okay, for 2019, what do I got to work on now with my clinic? TQRF, because the resource use and the clinical improvement pieces are not well developed yet, but just as she had said, resource use is only going to be about 10% on the front end, and then it's going to get up to that 30%. But notice, to make up the difference, quality measures, we've got TQRS, folks. 50% of 2019 is going to be tied to TQRS, and 25% tied to meaningful use. Guess where you need to be working, okay, as we get going. So, and you're going to hear more about this as we talk about metrics later today. So again, there's going to be the whole portfolio you're going to have to do, but on the front end, it's going to be loaded toward meaningful use and PQRS. Next slide, Dan. So, anybody overwhelmed yet? I just want to, right now, if you're kind of going, yesterday in North Dakota, about this point, there was a woman who got a little tearful, like, oh, I don't know how we're going to do this. So, and I just don't want to really have anybody tearful right now, because that's why we're here. We're all going to be okay. But if you look at this, and this is sort of what it feels like we're trying to do right now. We're trying to learn how to do this, and we're running faster and faster, and just as soon as we get a step, it moves on us. But I want to have you look at this a little bit differently. See, this I don't look at this as this is what the value treadmill is going to be like. This is what it's like as we're getting ready to do value. We have to do this. But the other thing I want you to do is just kind of look at this a little differently and think about where we are right now. Change that value to volume. Okay? Now, where are we right now on the volume treadmill? The federal government can't afford our current payment system, so what we do is we generate volume. We generate volume. As we generate volume, they can't afford us, so what do? They decrease our unit cost. Do our costs decrease? No. So what do we do to make up for a decreased unit cost? We increase volume. So then we increase volume, we generate more stuff, and then basically say, well, we can't afford this, so we're going to have to decrease your unit cost. That is truly a treadmill. And that's a treadmill. Basically, realize the reason we're moving the value is the volume treadmill is totally unsustainable. Okay? What's happening is we are getting to a point where our fixed price cost for care delivery is we're into the meat now. We aren't cutting fat. So we're at a point where this is beginning to challenge our sustainability. Okay? For the ability of this. The beauty of the volume-based system is it drives access to the hinterlands. But the problem we have right now is we're over volumed. We're at a point where we're going to volume ourselves right out of business because we don't have enough unit cost to have. We can't meet it with the volume. That's the rural challenge, folks. We can't make up on volume here because we only have X number of patients, but we also have to fix the cost per care delivery. That kind of makes sense? So realize, ready for this? Value-based reimbursement is your friend, okay? Where we're in the Midwest and the upper Midwest, remember I said I'd rather kind of be doing it here? We kind of do things together. We kind of do things because it's the right thing. So I actually have hope for us, for our ability to pull together community-based strategies and drive stuff. Okay? So, TCPI. What's TCPI? First of all, you look at this number, you see 140,000 physicians and clinicians. Before I actually explain what this is, 140,000, that's a big number. 140,000 physicians and clinicians. And Dan said earlier, the Compass is about signing up 7,000 physicians, and there's 500 and something. All those numbers make you glaze over. Okay, let me give you some context. To do the value-based healthcare system, we need to engage between 850,000 and 1 million physicians and clinicians across the country. That's that's the population that we're going to be dealing with in the country. We got to have between 850,000 and 1 million physicians and clinicians change the way they're paid, change and learn performance improvement, and actually this entity, this million, improve our way out of this financial issue we're in with the healthcare system. Okay, that's what the goal is. What's TCPI? Let's identify a subset of this big deal, down to 140,000 of folks who want to come together and actually work real hard to try to figure out the answers. Because if these guys can figure out the answers over a 4-year project, which is this project, TCPI, is about identifying and demonstrating sustainable new techniques to deliver care. If these guys can do it, guess what they're going to do? What we learn will be embedded in the rest of the system. It'll go into the payment system for CMS. So basically what you are is the sharp end of the sword. Okay? We're going to be trying to figure out how we do this first. You're going to learn before the rest of the country does it, basically. So what TCPI is, the major national initiative funded by CMS Innovation Center, provides hands-on. That would be improvement advisors in your clinic. We've got learning communities like this, and we're going to have web junk and all kinds of stuff. So provides resources to you, hands-on support to 140,000 physicians and other clinicians. Why? To develop skills and tools. It is not to get paid differently today. I don't pay you anything. This is basically, we're trying to help you develop skills and tools to move the APM ladder. Okay? What we're trying to do is take people at the mid-stage and figure out how can we best equip them and get them to move up the ladder the fastest. Okay? We're equipping you. In the process, we're making sure that you're successful at the mid-step. Okay? So developing skills and tools need to improve care delivery and transition to the alternate payment models. This is not about let's be MIPS, stay there forever. This is about let's not lose our butt in MIPS and develop skills that we can move up into the APM methodologies. Okay? You guys kind of got that? So, next slide. So now let's talk about the TCPI program, why we're here together. It aligns with the Affordable Care Act and the macro. I've already described to you the difference between the two. If we get, I don't care who gets elected, frankly, it's going to be very difficult to, those two pieces have to be considered separately. And don't let your physicians think that just because someone may have political views that we're going to repeal the Affordable Care Act. First of all, even if they repealed it, macro doesn't go away. Okay? But it aligns with both of those. It's building the evidence base for practice transformation. I can't underscore that enough. Listen to my mouth. Building the evidence base for practice transformation. This is the 140, learning how to change so that then they can just embed it into their thing for the rest of it. Okay? How do we change? And then basically taking the effective solutions and they're going to be scaled. What does scale mean? Putting into how everybody else has to do the work. We got 3 methods of moving practices through the 5. I'll talk about the 5 phases of transformation, but 3 different vehicles: practice transformation networks. That would be us. A practice transformation network is I'm a provider, I sign up for the PTN, and now I'm working with this cluster. This is my family as we work to improve together. A support and alignment network is the next ring outside of that, and they bring there are 29 practice transformation networks. There are 10 support and alignment networks that provide resources to help the PTNs do better. The SANs would be like the American Academy of Family Physicians, the American College of Physicians, which is the internal medicine docs. It's basically your big national organizations that are basically also telling the physicians and clinicians, this is really important, we're all changing, okay? And then the QIOs. Intelligent is here. You have also had the QIO from Plains here as well.
Yeah, well, I don't know if anybody's here yet.
Okay. Oh, that's right. He's here. So basically, the QIOs, ready for this? They're our partners. We got to figure out how we use the federal resources to kind of catalyze this transformation. What are the goals? For clinicians and their practice transformation goals. Think about what I just said. Support the clinicians. I mean support. That doesn't mean do it for you. Support the clinicians in their practice transformation goals. Most of you don't even know what practice transformation is yet, but you're going to have to set goals. How do we amend our clinics? So we're here to help you solve your problems. Get ready for this, folks? This isn't my problem. I'm not the one who's going to get paid for it. You are. So I'm here to help you make sure that you are adapting to that new system. Improve health outcomes, huge. Reducing unnecessary hospitalizations. We'll talk more about that as the day goes on, but it's basically, you'll see reduce unnecessary hospitalizations in TCPI, in the QIO scope of work, in the hospital engagement network scope of work. The reason I'm telling you this is everybody is working to reduce hospitalizations right now. Ready for this? Even the hospitals. The hospitals, because the hospitals right now aren't going to get paid for things that are deemed unnecessary, but they're still going to, if you admit people to their hospitals, they don't get paid. They really care about taking care of people that they're going to get paid for. So everybody's working on reducing unnecessary hospitalizations and then efficient care by reducing unnecessary testing procedures and junk. So CMS, you've seen this slide before, but CMS identified 5 phases of transformation. These look really simplistic, really performance improvement, really simplistic. But CMS has a pretty detailed way of measuring a practice's status if they're at level 1, 2, 3, 4, 5. But when I look at these, I kind of think of them as a clinical process, like the way we take care of diabetics. Well, first of all, before you can even do this, you have to say, well, can we even map how we do diabetics? So I kind of think this is the first phase of establish your processes. And then once you know how you do it, by the way, how we take care of diabetics has to be more than, well, Mary puts them in the roof. And that's kind of how most of us take care of it right now. But we've got to actually process map out how we take care of our diabetic population. When I was in practice, I had 107 diabetics. I can tell you every one of their names. I can tell you what their insulin does. I could not tell you my average hemoglobin A1C is. I couldn't tell you how effective I was at taking care of my diabetics, but I knew them all. Okay, and the whole point is we've got to figure out how we're going to do this, and then we're going to begin the process improvement journey. How are you going to do it differently? I'm going to measure if you did it differently. Okay, and over time, as you cycle between these two, you're going to start to move the bar. And as you move the bar for you, you're going to be able to do some comparison and start to actually compete at more of a national level. You're going to start hitting some national metrics. The interesting thing is when you're getting to hear you're probably going to start to think, are we ready to take a risk? Because we can block and tackle with Mike. We can actually do this differently. So, Compass PTN, that's what you were a part of. What is this thing? I'm with the Iowa Healthcare Collaborative. We are the primary contractor. The Iowa would not, when we were writing this grant, we didn't think Iowa would be big enough to actually compete for this. So we started working with Intelligent on a regional strategy. And we came up with, well, let's do multiple states. And but if we're going to do this, we can't do it so that, I mean, it can't be Iowa going someplace else and having the Iowa way done someplace else. You got to have it. You got to have the South Dakota discussion here. You got to have it be the way you do things here. So the idea of the Compass PTN, we call ourselves Compass rather than Iowa something. So the Compass PTN is basically a locally deployed. The idea is that you guys now have your own culture, and frankly, it will be more sustainable and more innovative. You will be driving your own local culture here. Okay. So in South Dakota and now North Dakota, we've subcontracted with HealthPOINT, and Dan's kind of the kingpin on this one, as we kind of bring these resources together. He's going to be responsible for the deployment of that. But we also have partners. Remember, there's 7,000 clinicians. We were contracted to come up with 7,046 positions. I mentioned earlier we're at 7,700 now. But South Dakota and Iowa are the dinks. 500, 700, 2,200, 1,500, 1,500, and then we also have Sanford Health System who's signed up with us as well. So that's what's gotten us at the high level. But the whole point is, I also would make a point here, while we are Compass, everyone across the deal, we also want to make sure that every one of these states have kind of their own sustainable culture. And look at the variety of our cultures. Iowa and Kansas are probably the most genetically the same because they both are run by collaborative organizations. Enhanced PHO. Oklahoma, we have two partners. We have Intelligent, which is taking care of the independent physicians. And we have the University of Oklahoma Medical School and all of their physicians and clinics. By the way, in Nebraska, we also have the University of Nebraska folks in that. And then Georgia, this is a hospital association for clinical needs. So we have great breadth with regard to expertise kind of running what we're doing. Next slide. So there are 29 PTNs. There are some kind of unique, they're not all the same. They're dramatically different. The largest is one in 3 states. It's called Great Lakes. Michigan, Illinois, Ohio, I think. But they're the largest. They have 12,000. We're the second largest at 7,000. How often in South Dakota have you been the second largest of anything? Okay, we are the second largest PTN. Okay, and then they drizzle all the way down to some PTNs that are only as large as 500. But there are some things that are unique about us. The first one is we know how to do this. The Iowa Healthcare Collaborative has been a collaborative since 2005. We got a lot of experience. We were a HEN. We were not a HEN, Hospital Engagement Network. We were a freestanding hospital engagement network. We were not a subsidiary of somebody else. So we have the experience dealing with this and doing the contracting with CMS. So we know how to do this stuff. I guess another thing about this one, though, is our DNA is provider-led. Okay? We really believe that the most innovative and sustainable transformation will happen if the provider community actually engages and drives the transformation rather than reacts to the payment mechanism changing behind us. And why would I do that? Okay, all right, I'll do this. Okay. I mean, that's the way we kind of have responded in the past with payers. We believe we got to break it and fix it. We need the provider community that wants to have to lead that. So we're really into a provider-led strategy. Next slide. The second piece, now I'm talking specifically to your clinics. We want to committed to meeting clinics where they are. I'm not going to go through all the stuff in this slide, but basically, you have your own unique culture, you have your own unique performance, you have your own unique community, you have your own unique statutory environment, and I can't come in and say, thou shalt do all of this stuff to get to a precursor level, and then we can begin to improve. We got to meet you where you are, and then try to figure out what you got, and then what are the problems you have to solve, and then facilitate you solving your problems. So that's kind of one thought. Next point. We also, the way we help you fix your problems is we resources, and we aren't going to kind of say, you have to do it this way. We're going to bring the resources. We're probably going to bring the solutions that other people have had, other people have tried. It's going to be more of a menu of things, but you got to figure out what's the best thing that applies. The challenge for you will not be having resources available. The challenge for you will be execution. It's not going to be having the menu. It's going to be actually doing the menu. And that's kind of another thing about us is that we're not here to kind of, oh, let's go find the answers, or let's just give you an educational program and be changed. We're really here, we're going to be here holding your hand saying, okay, what are you doing? What's your data look like? And how's that working for you? What should be changed? It will be execution focused. Okay. Next one. Finally, we've got a lot of resources available to you. We're going to be touching in a lot of ways. We're going to have quality improvement advisor assigned to every clinic. There will be like, okay, you give them all this stuff, I don't even know where to start. The first thing that's going to happen is this practice assessment. So within a month to 2 months of you signing up, you should have your practice assessment tool completed. Anybody completed their PAT yet? Okay, so practice assessment tool basically is like, oh, where are we starting from? It is a good assessment of where you are. It's, I don't know, 50 questions or something like that, but it's basically something where it helps you understand where you are. And I'll talk more about the practice assessment tool later, because that practice assessment tool is something you're going to use about every 6 months to assess how you're doing as you go forward. So we're just going to start with the practice assessments. You're going to have on-site support. We have a faculty of about 6 people that are available in Compass. 2 of them are PCMH physicians. One of them is a pharmacist who's been national expert on medication safety and effectiveness. We got 2 folks who are performance improvement experts who can kind of help out as we need to. So then we've got a biostatistician to kind of help do the analytics and stuff. So we've got faculty resources. There are also several national faculty that will be available as well. And then we're going to have these collaborative things like this is a learning community, and I hope next year when we do this, there's going to be like 150 in the room, because you're going to drag at least 2 physicians from each of your clinics to this. And you can imagine, there's only a couple of providers in the room, but I'm actually pretty good at going face-to-face with providers and going, get over yourself. So it's basically, that's kind of where we need to be going on this stuff. We got to move. So learning communities, and then we're going to have some web-based support as well. Next slide. So this is really kind of, you've all seen this one, but it's just a good thing to remind you, like, why would we do this? Why would we do this? Well, we want to optimize healthcare outcomes and improve safety. Why? We want to improve healthcare outcomes because we're not going to get paid if we don't have good outcomes in the future. We want to improve safety because if we don't improve safety, those are unintended consequences of care which cost money to the system. So this is about, and by the way, one of the biggest things that you need to ask your physicians whenever they start to push back is you need to say, but is this good medicine? And the fact is, this is good medicine. There are very few clinicians that are going to push back. They're going to say this is inconvenient, this is pain in the butt, but the fact is this is the right thing to do. So doctors, shut up and get to work. Okay. Learn how to achieve and maintain benchmark status. Again, thrive under macro is the best way to look at it. Get ahead of the 2015 reimbursement curve. And then, frankly, we need to build a South Dakota strategy. We need to build a South Dakota culture. You guys already have it. I know you're spread all over the state, East State, West State, all that stuff. But the fact is, you guys, there's an opportunity for you to come together and create a feel for how we do it here. By the way, if there's any hospital association, medical society people here, do you think having the providers actually lead performance improvement does anything to help your advocacy efforts in the state? Duh. If the providers are actually leading rather than just arguing about how much you pay us and what scope of practice is, scope of practice becomes irrelevant as you keep going. Get about the business fixing care. Next slide. Okay. I mentioned Berwick. Okay, now I'm going to get you guys to students here. Okay. But Berwick was kind of the godfather of performance improvement, and he came to CMS and he had those 4 things: the transparency and collaboration, patient first, all that stuff. Well, he presented at a meeting in December, and he came back to CMS. And at that meeting, he said, basically, congratulations. Did anybody ever see the movie Karate Kid? Okay. Well, the Karate Kid, remember in the last part of the Karate Kid, he's in a competition, a karate competition. Mr. Miyagi is his mentor. And Mr. Miyagi, the kid is just getting a tar beat up. I mean, just getting walloped. And he comes over at some break and he says to Mr. Miyagi, so what do I do? And Mr. Miyagi goes, move faster. And I just remember that, move faster. And so what happened with CMS was Mr. Miyagi, they had a Mr. Miyagi moment in December. And Don Berwick was there, and he came back to CMS, and he applauded them for the changes they've been making over the last several years. But he said, now, we need to be thinking that as we go forward, we really need to be thinking about radical redesign. And there are components. It's not just breaking everything. There are components. There are things you need to be aiming for as you do radical redesign. And he gave 10 elements of radical redesign. I want to share those with you because when you think about it, because if nothing else, when you go home, you got to kind of have this stuff in your heart as you go forward. Because if you don't, you're going to wear out. You're going to get diminished just by the pain and the constant obstacles you're going to run into in the clinic. So these are Berwick's elements of radical redesign. By the way, this is kind of a funny story. Before I do this, I was in South Carolina a month ago, and Don Berwick was at the meeting. And Don's a friend of mine, but Don and he's going to give this presentation, and I hadn't seen him for a long time, and I said, hey, Don, are you going to use your 10 elements of radical redesign? Because I'm using the same elements later. He goes, oh, yeah, I got them in there, but I'll skip them, and you can do it. So I got to do Don Berwick's radical redesign at his meeting where he didn't talk. Anyway, so we thought we'd do it a little differently anyway. But number one is changing the balance of power. The balance of power at this point is all about who submits the charges. And the fact is, and remember, we have every one of our fishermen all in different boats fishing as fast as they can. And we can't do that. We're going to have to change the balance of power to co-production. We've got to run plays together. We're going to have to start thinking about how we do things together. And a very important component of the co-production is the next presentation. We've got to engage the patients. They have actually not to be the throughput of our system, not to be the thing that's standing next to us as we deliver care, but actually a co-producer as we go forward. So start thinking about, by the way, this is going to be threatening for your clinics, because right now we have a system, and our system does this, and our system is built to protect itself. It doesn't want to change, it wants to protect itself. You're going to have to break the system a little bit, okay? We'll talk more about that. Change the balance of power. Number two, I like to do two and three together. Standardization. You're going to have to standardize, at the same time you're going to have to customize. Think about data. Okay, all this data we have today, 10 years ago, we didn't have nearly as much data, nearly as much as reporting responsible as we do. And now we have all this data, but a lot of the data, does it drive anybody else nuts that a lot of the data that we define and we report is defined differently from different organizations? Okay. Like in our HIM project, we actually had a measure that we were trying to track on blood sugars, and we asked all of the hospitals to report on just how often did we drive someone's blood sugar too low? How often did we drive them with the blood sugar less than 50? And we asked the hospitals to begin to report that. We very quickly found that they were reporting blood sugar less than 50 in 3 different denominators: 1,000 patient days, 1,000 patients, I can't remember what all of them were. But basically, we had to go through a process over a course of a year, reducing it down to one way of measuring it. Oh, that was painful. But the whole point is, we need to standardize what we're doing. Don't create your own measures. Wherever you possibly can, go find out what's out there nationally and use those definitions and then out-execute everybody else. Don't be clever. This is about execution. That's standardization. At the same time we're working to narrow the definitions and standardize, we've got to customize. We've never done this before. We don't know what we don't know. There are many processes, new processes that we're going to have to develop and start to track. Like that hemoglobin A1C for my diabetic population. I didn't have a hemoglobin A1C for my diabetic population. Back then, it wasn't important. It was just how many office visits I saw. Now, how effective my hemoglobin A1C looks for how I manage populations will probably be a PQRS measure that's going to determine my payment. Have a nice day. Okay? So we're going to have to customize. We're going to have to find those new things. So standardized, creative enough in creating the new measures, and then it's back to full circle and as great as you can. Okay? So but this is the crazy part. Promote well-being. I know you all go, well, we promote well-being, don't we? Don't we? No, we don't. We promote being well. Matter of fact, if you're not well, you need to be in our office. We focus on disease. We explain disease. Everything's fixing people, but we don't really focus very effectively on keeping people from getting broken. We need to think about a whole different strategy about how we actually are taking our patients now and keeping them from getting broken, rather than just identifying minuscule things for us to fix and charge for as we go forward. Joy in the work. It sounds so schmaltzy, but I got to remind you guys, my best analogy in this one is my son. I've got a son who now is a hospital administrator, but when he graduated from college, he had a business degree and a psychology minor, and he decided to go, got a great job with Target Corporation. And he was going to become a store manager. Okay? So there's a training, about a year training program that they go through, like an internship they go through. At the end of this deal, you become a store manager, they assign you someplace. These guys make a lot of money. So he had a really good job. And he was about 5 months into the program, and I got a call one day, and he says, Dad, I think I'm going to go to graduate school. I think I want to apply to get a master's in healthcare administration. Why do you want to do that? You got a great, why do you want to do that? He goes, well, I'm doing this business stuff, and this is all great, but there's just not a heart behind it. And I want to do it in some place where I'm actually helping. I want to know that with the product that I'm generating, right now I'm so proud of talking, but I want to do it someplace where it matters. Do you realize that where you work right now, what you do matters? You're creating a sustainable healthcare system that is basically providing services for your communities. You're helping people. You may be a part of the machine, but you're helping people. And you're helping your communities. And you're helping your state with what you do. We need to revel in that a little bit. We should feel good about what we do. We aren't just selling gold on the internet or something. But we're actually making people's lives better. And I just hope you take a moment at some point, pinch yourself and go, this is how I want to spend my minutes in this. Okay, next slide. Make it easier. This mentions lean manufacturing techniques up there. That's basically saying I don't care what you use, but you better brace something. Okay. Now there's there's PDSAs, and there's lean, and there's ISO 9000, and there's Six Sigma, and there's black belts, and there's all this other stuff. I look at those almost as like a bunch of performance improvement religions. And most of you have had someone bring a product in, overlay your system, and we're going to do this, and we're going to be better, and that's great. But the fact of the matter is, I'm going to make it real simple for you. You got to do less. I like lean because it does it. If you look at, like, this is just an example. We have so many things that we add layer upon layer upon, and the processes get more and more cumbersome, and we don't have the resources. Here's a story, is that the process of giving somebody an aspirin in the hospital, someone process mapped it out one time, and from the time the doctor thinks of it to the time it is in the patient's mouth, there are 17 steps. Now, if every one of those steps has a failure rate of 5%, okay? You add up all of those 17 steps, the chances of actually executing that entire process correctly is only about 50-50, okay? Just because there's so many steps. How do you improve this process? You decrease the number of steps. What extraneous steps are in there? You identify things to not do. So be thinking about how we do things. Start to think about the discipline of, do we need to do this? Why do we do this? We've always done it that way. Well, maybe that's not a good enough reason anymore. Maybe we need to start thinking about how we change our processes so that we can make them more reliable. the first step for performance improvement is to decrease the variability. Start to decrease the variability, decrease the number of steps, and you're going to improve your reliability as you go forward. Modernization. You know, this one, like you kind of go, oh yeah, we've got electronic health records. Really? Did it modernize you? Did it really? Did it really help you? I mean, it's not about having them, it's about using them. Did it really make the tasks better? And I know this is one where everybody's going to have an opinion right now, but modernization means being willing to let go of the way we always did it and adopt new techniques that will just break everything you did. My father-in-law developed Alzheimer's, and we moved him into a home a while back, but I had to clean out his garage, and he was a plumbing contractor, and he was a very good plumbing contractor. He had all of this stuff in his garage. He had, and I'm kind of a fix-it guy, so I like this junk, but he had all these soil pipe cutters and stuff that you could melt, and all this really cool stuff that he hadn't used for 30 years, but it was all this stuff in his garage. And when he left, I had to kind of clean it all out. And I'm thinking, wow, I got all this valuable plumbing equipment. And then I started looking at it, and I realized they don't even do that anymore. They don't use soil pipe, which is cast iron pipe. They use a kind of a PVC that just goes in the ground. I got all this stuff now that is antique plumbing stuff. Okay, so I mean, it's basically, I had all the highest grade commercial level stuff that wasn't relevant anymore. Another example of this is on modernization. We need to modernize. We moved into our house in 1988, and I was so proud because our house was wired for cable. Oh, it's cool. You know, wired for cable. We put 2 TVs in. I thought we were so cool. So and then we you know, put another TV in, and got to the point the signals get pretty weak, so we had to, of course, we put splitters on, and then I had to boost the signal for the splitters. So, and then I got kids, and they need to have this, and so now so we're up to like 7 TVs. So I got like 3 splitters and 4 boosters, and make sure the signal's all good. Then we add an addition onto our house, which had a basement and an upstairs, so there's a TV in each one of those, more splitters, more boosters, and I got this system just right. And then I went to Menards. And I'm at Menards, and my wife and I are walking along, and there's this chick selling satellite, and it costs about half of what I'm doing right now. So, oh yeah, we'll put satellite. So satellites all scheduled. They're going to come to our house. They come to our house, and I took the afternoon off. I'm there, and this guy comes in, and he goes, "Whoa, this won't work." What do you mean it won't work? Well, we have to have different splitters and different boosters, and every one of those, if you did that, you're looking at about $1,200 for all this stuff. And, oh, I'm not sure I want it then. He goes, well, there's another alternative. We can put a satellite on your roof and then have it come down to a TV, and then we'll hook up a wireless where that TV is a transmitter and it sends out a signal throughout your house, and then the other TVs will pick it up. Really? Yeah. So he set it up, and I got TVs all hooked up now, and I got a house full of cable and splitters. It doesn't work anymore, but the whole point is the new solutions can be much better, and they're paradigm breakers for us. So we need to be thinking about adopting these things. Collaboration, this whole day is going to be about collaboration. We've got to work together. And I know you all work for different teams. I don't care. I don't care what system you work for. I don't care what department you work for. I don't care if you're with a QIO or you're with a hospital. So I don't care. This is actually creating a sustainable system for your state. This is about the provider community, us as a family, figuring out how we do this differently, executing change. And the last 2 are really important. You look at those and it's like, oh, those feel like they're dollar things, but they are. Okay? The United States ranks 37th in the world with regard to the healthcare quality, but we're number 1 in the world with regard to cost. And we're not like cost per capita, and we're not number 1 by just a little bit. We're twice expensive as the next most expensive country, which is Denmark, and they don't even have an army. Okay, so the fact is, we spend a lot, we have a lot, and our execution is not very good. There are many countries that have a lot less and do a lot better with what they have. We have enough. we can do this, and we should do this. And the last piece on returning the money is we have to do this. One of the things that Dr. Burbick closed with was a graph. He ran for governor. He wasn't successful. He ran for governor of Massachusetts, and he has this graph of Massachusetts expenditures. And on the top here was Medicaid expense, which is basically a sampling of how much we're spending for healthcare costs. And the Medicaid cost curve is going up like this. And then he had two other budget lines from the Massachusetts budget. One of them is law enforcement, and the other one is education. And they're both, first of all, they're down here, and they both are doing this. And he put a term to it. We call it confiscation. You know, we can't continue to waste dollars. You know, the estimate is that there's about 40% waste in the healthcare system. We can't continue to inefficiently leak resources that are needed other places in our society, especially at a time like when we've got access to our education system the way it is. So we have kind of an ethical and moral imperative to the provider community to fix this. So with that, I'm going to stop there and just ask if anybody has any questions or comments. Yes. Yeah. You know, here's just a comment about that, and congratulations. I've talked about some of the stuff with legislators before, and I've talked about Iowa's pretty good. But an example of that is like Iowa, the cost per capita, we're right near the top nationally with regard to value in healthcare costs. And the United States sucks, right, in healthcare costs. So can I say that on tape? It sucks. Anyway, I guess I did, right? It sucks. So anyway, but the point I want to make is that I was making this point, and Iowa looks pretty good, and I have this graph from Nolte and McKee that I put up on. It's just a metric on countries' performance on the ability to respond to. It's like amenable to health care means they died and they shouldn't have. Okay, so we rate these countries, and they shouldn't have died. We should have been able to fix them. And it rates the top 16 countries. And the United States of the top 16 countries, the United States ranks 16th. Okay, and then it goes down to number 1, which was France. Okay, but so I present that, and I talk about how the United States is bad, and then I had a legislator say, so if Iowa was so good, where would Iowa be on that? And I would kind of pose the case. If South Dakota is so good, where would South Dakota be on that? And we're actually pretty close on this. So Iowa, out of 16, if Iowa was a country, would have ranked 12th. Okay? So even though we think we're good, it's because we're comparing ourselves to the crap. Now the interesting thing was, I thought it was interesting that like number 13 on the list was Great Britain. Oh, the British healthcare system. And some of the, Iowa was better than some of those other countries, but we're worse than Greece. And Greece is broke. So the point I'm making is that we in the United States, we have to remember that we're the cream of the crop. And we have to we've got to change. Yes?
I have a question on the mid-score. When the score is calculated, is it calculated at the provider level or the medical practice level or system level? How is it going to be?
That's a great question, and it's kind of TBD. Remember with MIPS, we have the law, but the administrative rules are still being written. The administrative rules, the first iteration was just released last week, and now there's a 2-month review period where people can throw fruit and do all that stuff. But I think it's probably going to be an iteration of both. For a clinic, it'll probably be like the clinic, but again, you can't. Then you got to go into the business of clustering clinic sizes to actually compare. So you're going to want to get as close to the you want to attribute as close as you can to the physician level, but the closer you get there, there's attribution issues. So the best way to answer this is I don't know, but that's all the issues that we're going to have to deal with it. So how do you meaningfully compare and how do you attribute are the two pieces? There'll be probably some middle position. Other questions? Yes, Steve.
Any comments, thinking back foundation of historically, encourage hospitals to PRS.
Yeah.
And in the last, they were supposed to work our contract. We had some pretty clear, but for many of them are under the payment system on our provider say private not qualified.
Right.
We did rural health, I think, federally qualified health, community-based.
Yep.
All of a sudden, you've got 5 or 6 different payment systems,
Yep.
some of which use quality reporting, some which don't. You didn't, are the rules going to take into effect under that kind of payment system, or they would be under the wire?
Well, I have a couple of thoughts on that. The first one is this is a unique environment where, I don't know what percentage of your overall provider base this would be directly applicable to, but you've already mentioned you have a fairly sizable component where it's not. Now, so I don't know how that plays out. I know that it's going to be figured out as we go forward and get administrative rules and other stuff. But even yesterday, like in North Dakota, we were talking about this, and I had an FQHC clinic manager say, well, this isn't relevant for us. However, matter of fact, the head of the membership organization for the FQHCs was kind of saying, well, this doesn't apply to us, and kind of posturing politically. But this FQHC guy basically said, yeah, for how long? And the fact of the matter is maybe we aren't there now, but I kind of, this is my thinking on this. It's the same thing as the critical access hospital staff, which is your PPS hospitals have had these payment incentives up here to do quality at a higher level, or basically we're not going to pay if you don't. And then we have the critical access hospitals that are paid at this level no matter what, where a readmission here, you guys get penalized if it's a readmission here, or readmission is an admission. So the point is, if these guys are incented to continue to improve their performance and get better and better, and these guys aren't, do you think that two-tiered system is going to be a sustainable system? And what's going to happen is, my county, Iowa is we have a very high number of critical access hospitals. We keep telling our critical access hospitals, I know you get paid here, you better be thinking you're going to be up here, because imagine for this two-tiered performance system, if you've got a two-tiered performance system and everybody else is up here and these guys are down here, paid differently, and we've got to go through revenue contraction, geez, who would be easy to get rid of?
Senator Grassley for changing the whole structure.
Well, but the good news, yeah, well, the purpose on that one was he's trying to sustain the system, which is basically this system. The critical access hospitals can't continue to contract down to nothing, so they need to change it. You need a delivery system, but it's kind of saying, okay, do we need to have a lot of bed capacity here, or do we just need to have 24/7 emergency services and other stuff that we need within the community? We need to have that presence, but it's not the same presence it was. It's not inpatient capacity. So, but the bottom line on that is, do you think this doesn't apply to you? I'm telling you, if the rest of the world is doing this and you're doing that, and if they're going to go through revenue contraction, you don't want to be the low performing entity. So you don't want to give them that excuse to cut your head off. So that's my perspective. You better do that's what Other comments? Okay, we're over time, so let's take a break, okay?